Okay, welcome to today's presentation. Today we will explore a lesser known but deeply consequential aspect of diabetes, and that is diabetic autonomic dysfunction. While diabetes is often framed around glucose control and vascular damage, there is a more insidious player at work, one that quietly disrupts the body internal balance, undermines safety, and diminishes quality of life. It operates quietly without striking laboratory results or clear symptoms, yet its impact is deep and far reaching. Today we bring this hidden complication into focus and confront the silent threats it poses. Now, let me give you my outline. Now, to confront these silent threats, we need to understand what we're truly up against. Today's session will walk through the full landscape of diabetic autonomic dysfunction, from its hidden origin to its multi-system impact, and from subtle warning signs to strategies for diagnosis and care. We'll begin by defining autonomic neuropathy in the context of diabetes, then explore its pathophysiology, the system it disrupts, and the clinical clues that often go unnoticed. Finally, we'll discuss how to detect it early, manage it effectively, and anticipate its long-term consequences. So let's begin with an overview of the autonomic nervous system. The nervous system consists of the central and peripheral parts. The peripheral system is subdivided into sensory nerves, which sends information to the brain, and motor nerves, which control the body's action. Motor nerves further split into the somatic system, managing voluntary skeletal muscles, and autonomic system regulating involuntary smooth as well as cardiac muscle through sympathetic and parasympathetic branches. The enteric system or the enteric nervous system, often seen as the third branch, operates semi-independently within the digestive tract but stays connected to the autonomic system, and each system has distinct neuronal structures suited to its specific function. So in summary, on the right side of the slide, the somatic nervous system governs voluntary skeletal muscles, while the autonomic nervous system regulates involuntary smooth and cardiac muscles, with each system displaying distinct neuronal structures. Now, the autonomic nervous system keeps the body balanced. Sympathetic system um, from the thoracic and lumbar spine activates fight or flight, speeding the heart and slowing digestion, while parasympathetic from the brainstem and spinal cord promotes rest and digest, slowing the heart and boosting gut activity. Like the yin and yang, they work together to maintain physiologic harmony. Though often opposite, the sympathetic and parasympathetic system also work together in vital body function. During urination, the parasympathetic system contracts and the bladder, while sympathetic inhibition relaxes the sphincter. In sexual activity, parasympathetic triggers arousal, while sympathetic finalizes orgasm. Okay, so diabetic autonomic neuropathy is a nerve damage from prolonged high blood sugar or hyperglycemia that disrupt autonomic function like heart rate, digestion, and blood pressure. It's called silent because symptoms often go unnoticed until late stages. It affects 20 to 50% of diabetics, more commonly in type 1, and when cardiovascular involvement is present, 5-year mortality can reach up to 50%. Now, diabetic autonomic neuropathy affects several organ systems, with cardiovascular involvement being the most extensive studies. Nonetheless, recent findings underscore the growing recognition of other forms such as gastrointestinal and urogenital autonomic neuropathies for their substantial impact on both healthcare demands and patient quality of life. Pseudomotor dysfunction occurs less frequently compared to other features of diabetic autonomic neuropathy. Hypoglycemia awareness is a metabolic outcome of diabetic autonomic neuropathy that impairs the body ability to recognize low blood sugar. It presents significant challenges for the safe management of diabetes, and abnormal pupillary responses, though recognized as possible manifestations, receive relatively less emphasis in the large-scale studies. Now, these last or final two topics won't be covered in today's session, but we may explore them in a dedicated presentation in the future. So, what's the prevalence of cardiovascular autonomic neuropathy? The reported prevalence of autonomic neuropathy is primarily derived from the studies on cardiac autonomic neuropathy, or CAN for short, which is the most frequent, well-researched, and clinically important subtype compared to others. In a large cohort studies, CAN has been observed in up to 44% of people with type 1 diabetes lasting more than 20 years, while earlier research in those with long-term type 2 diabetes show prevalence rate as high as 60%. Here's the summary and the big pictures of the prevalence of cardiac autonomic neuropathy. The prevalence of cardiac autonomic neuropathy varies by diabetes type and duration. The newly diagnosed type 1 diabetes rates are low, as seen in the DCCT primary prevention cohort. However, in those with over 20 years of type 1 diabetes studies like DCCT, EDIC, Eurodiab, Pittsburgh EDC, and Steno studies report rates up to 44%. Among individuals with type 2 diabetes, cardiac autonomic neuropathy or CAN, prevalence reaches approximately 13% in the early disease, rising to as high as 60% in long-standing cases based on earlier observational data. Here are important differences in the pathogenesis of cardiovascular autonomic neuropathy between type 1 and type 2 diabetes, though they also share common mechanism. So while both types shares core mechanism like oxidative stress and mitochondrial injury, etc., type 1 DM related CAN is more glycemic driven, whereas type 2 related CAN reflects a broader metabolic and vascular burden. Now, the pathogenesis of autonomic neuropathy developed through a complex and yet not yet fully understood set of mechanisms. Contributing factors include hyperglycemia or chronic hyperglycemia, disruption of metabolic pathways, inflammation, immune-related nerve injury, and lack of essential growth factor. The glucose hypothesis suggests that persistent hyperglycemia activates alternative biochemical routes that produce harmful substances like advanced glycosylated end products and free radicals. These changes lead to a direct nerve cell damage, reduced blood flow to the nerves, and injury to the vascular lining, the process that are also observed in diabetic peripheral neuropathies. Now, this slide re-emphasizes that the onset of cardiovascular autonomic neuropathy is frequently insidious with no apparent symptoms at first. Initial parasympathetic impairment often goes unnoticed but leads to a relative increase in sympathetic activity, commonly presenting as resting tachycardia. With disease progression, sympathetic dysfunction emerges, manifesting at clear clinical features like orthostatic hypotension, reduced peripheral blood flow, as well as cardiac irregularities. Now talking about vagus nerve is typically affected first because it is the longest autonomic nerve in human body. Loss of parasympathetic tone result in a compensatory increase in sympathetic tone with the resultant elevated norepinephrine levels and insulin resistance. All of these changes reduce cardiac efficiency and ultimately can contribute to cardiac remodeling. An increase in resting heart rate is due to vagal nerve damage with resulting unopposed cardiac sympathetic outflow. As autonomic neuropathy progresses, the sympathetic nerve system is also affected. So exercise intolerance results from impairment of heart rate, blood pressure, and cardiac output in response to exercise. Late-stage autonomic neuropathy results in orthostatic hypotension. Now, cardiovascular autonomic neuropathy contributes to increased illness and death. People affected with CAN face a greater likelihood of cardiac arrhythmias, silent MI, and sudden cardiac death. In this Horn study, on your left, demonstrated that patients with impaired vagal tone, characteristic of CAN, experience reduced survival. Additionally, another study on your right found that lower heart rate variability is associated with decreased cumulative survival over time. The cause for increased mortality is attributed to abnormal norepinephrine signaling resulting in cardiac arrhythmias and sudden death. Autonomic neuropathy is associated with prolonged QT interval, which is also an independent predictor of mortality. Furthermore, the presence of CAN impairs the ability to detect cardiac ischemic pain, leading to silent myocardial ischemia and infarction. The progression of CAN moves from parasympathetic withdrawal to sympathetic failure, raising the risk of serious outcome. Early stages may be silent, so tests like heart rate variability, analysis, and checking for resting tachycardia or a fixed rate or fixed heart rate are crucial for early detection. So what is heart rate variability exactly? Heart rate variability is the variation in times between consecutive heartbeat measured in milliseconds. While your heart may beat a steady rate, say 60 beats per minute, it doesn't mean each beat is exactly 1 second apart. In fact, healthy heart have subtle dynamic fluctuation in timing, and that's a good thing. In other words, each heartbeat isn't typically spaced. Small timing shifts are normal and healthy. So heart rate variability is a window into the autonomic nervous system balance between parasympathetic and sympathetic activity. A higher heart rate variability generally indicates better adaptability, recovery, and resilience, and a lower heart rate variability may suggest stress, fatigue, illness, or autonomic dysfunction. So, for recognition, there are 5 classic Ewing tests that are a standardized set of cardiovascular reflex tests developed by Dr. D.J. Ewing to assess autonomic nervous system function, particularly in the context of diabetic autonomic neuropathy. These tests are non-invasive, relatively simple, and remain the cornerstone in clinical evaluation of autonomic dysfunction. The first test is heart rate response to deep breathing. This test assesses parasympathetic function by measuring heart rate changes during deep breathing. Normally, heart rate rises with inhalation and falls with exhalation. So the E expiration ratio, I inspiration quantifies this. A lower ratio indicates parasympathetic dysfunction. On your right, the diagram illustrates that a well-functioning parasympathetic system produces smooth heart rate variation during breathing. When this response is weak, showing little change, it suggests diminished vagal tone, an early sign of autonomic imbalance. The second is heart rate response to standing, or the 30 is to 15 ratio. This test evaluates parasympathetic function by measuring heart rate changes from lying to standing. A normal response show a peak at beat 15 and a drop by beat 30. The 30 is to 15 ratio reflect this. A lower ratio suggests the autonomic dysfunction. On your right, the diagram, when patient is standing, the autonomic system suggests that heart rate to stabilize blood pressure. A normal 30 is to 15 ratio shows a peak at beat 15 and a drop by beat 30. Now, a reduced ratio suggests early parasympathetic dysfunction often before symptoms appear. The third test is the heart rate response to Valsalva maneuver. The Valsalva maneuver is you tell the patient to forcefully exhale against a closed glottis, like blowing into a syringe for 15 seconds. Sometimes you need a manometer to measure at least a 40 mmHg for 15 seconds. Okay. Now, this test evaluate both sympathetic and parasympathetic function by measuring heart rate changes during forced exhalation. The Valsalva ratio reflects this response. A low ratio indicates autonomic dysfunction. On the diagram on your right shows heart rate changes during the Valsalva maneuver. A normal response follows a 4 clear phases ending with parasympathetic recovery. In the abnormal autonomic response, the phase 3 is often absent or blunted. Heart rate barely dips after strain release. This loss of variability begins or signals impaired vagal tone, a subtle marker of early diabetic neuropathy. Now, the fourth test is the blood pressure response to standing, or the orthostatic hypotension test. This test reflects sympathetic vasomotor function by comparing blood pressure lying down versus standing. A significant drop of equal and more than 20 mmHg of systolic, or a equal or greater than 10 mmHg diastolic indicates orthostatic hypotension. On the diagram, it illustrates when patient is standing, gravity lowers blood pressure and the sympathetic system should compensate. A slight systolic drop is normal, but exaggerated drop significant or signals orthostatic hypotension, which is an early sign of impaired sympathetic vasomotor tone, especially critical in diabetes. And the last one is blood pressure response to sustained hand grip. This test assess sympathetic function by measuring diastolic blood pressure after sustained hand grip. A normal rise is equal to or above 16 mmHg, and a rise of equal or less than 10 mmHg suggests a sympathetic impairment. In the diagram, the sustained hand grip test checks sympathetic vasomotor tone by measuring diastolic BP during a prolonged grip. A rise of equal and more than 16 mmHg is normal. A blunted rise that is equal or less than 10 mmHg signals impaired sympathetic control and potential cardiovascular instability. Now, here's a summary of the 5 Ewing tests used to assess autonomic function, outlining which branch they evaluate, either sympathetic, parasympathetic, or even both, along with their clear procedures and the expected normal versus abnormal response in a table form. Now, clinically, Ewing test scores ranging from 0 to over 3 help detect early autonomic dysfunction, a guide management decision, and monitor disease progression, especially in patients who show no clear symptoms. Now, let's go to the management. There is no cure for CAN yet, so we focus on symptoms relief, tight glycemic control, help in type 1, and in type 2, we target blood pressure, lipids, and weight, and other comorbidities. Lifestyle changes can improve autonomic tone, especially in prediabetes. Emerging risks include glycemic swings, vitamin deficit, inflammation, and genetics. SGLT2 inhibitors may offer new autonomic benefit, such as in this next slide, and newer anti-diabetic drugs, as mentioned before, like SGLT2 inhibitors may support autonomic and metabolic health. This is a 2019 review by Vicente Espalion, highlights their potential to improve heart rate variability, lower resting heart rate, and stabilize blood pressure, while also aiding glucose control, weight loss, and BP reduction. This combined effect may help slow the progression of cardiovascular autonomic neuropathy. Another agent, GLP-1 receptor agonist, may help restore autonomic balance in type 2 diabetes by enhancing heart rate variability, dampening sympathetic overactivity, and promoting blood pressure stability, offering cardiovascular advantages that extend beyond their glucose lowering effects. Now, so we go to the other subtype of diabetic autonomic neuropathy. First is the pseudomotor dysfunction. Pseudomotor dysfunction is in diabetes, reflect damage to sympathetic cholinergic fibers that control sweat glands, especially in the lower limbs. It leads to reduced sweating, anhydrosis, heat intolerance, dry skin, and compensatory upper body sweating. This stacking pattern increases the risk of foot ulcers and infection. Though acetylcholine is involved, the pathway is purely sympathetic and not parasympathetic. As you can see in this slide, pseudomotor dysfunction in type 2 DM shows a dual pattern. Early on, patient may experience excess sweating, including gustatory sweating on the face or scalp after meals. In advanced stages, on your right, it shifts to reduced or absent sweating, especially in the feet, leading to dry, cracked skin and increased risk of ulcers. Now, the Q-SART test evaluates small fibers neuropathy by triggering a pseudomotor axon reflex. Now, acetylcholine is applied via iontophoresis, indicated by black arrow, stimulating sweat glands directly and indirectly. The nerve signals first travel backward antidromically and then forward anterogradially to activate nearby glands, producing a measurable sweat response that reflects autonomic nerve integrity, as shown by dotted arrows. Now, the management of pseudomotor dysfunction focus on the symptoms relief and skin protection. Avoid systemic anticholinergic, for they can worsen anhydrosis and raise heat stroke risk. Use emollient and breathable footwear for dry skin and topical agent for hyperhidrosis. No therapy reverses nerve damage once established, though SGLT2 inhibitors may offer indirect autonomic benefit, but this still under investigation. Now, effect on diabetic enteric neuropathy on a GI tract includes impaired motility and coordination, contributing to symptoms like gastroesophageal reflux disease or GERD, or gastroparesis, and others. Now, gastroparesis caused by a delayed stomach emptying leads to vomiting, abdominal pain, and weight loss. It increases the risk of malnutrition and poor absorption of oral medication, worsening glycemic control in DM patients. However, it is important to exclude all other potential causes of gastroparesis, including numerous other factors, with special attention to medication, especially diabetes medication such as GLP-1RA. The earlier data on gastroparesis are scarce, but one major U.S. study found it's more common in women. Though confirmed cases tied to diabetes remain low, hospitalization are increasing, possibly linked to rising use of medication like GLP-1RA, opioid, and marijuana and others. The exact cause, however, remain unclear due to lack of well-designed studies. The American College of Gastroenterology 2022 classification for gastroparesis uses symptom severity and functional impact to guide treatment, starting with a diet adjustment and progression or progressing to medications or procedures based on patient's need. Diabetic gastroparesis and glycemic control influence each other. It's a vicious cycle. Hyperglycemia shows gastric emptying, worsening symptoms, while delayed emptying disrupt glucose absorption, causing mismatched insulin timing and hypoglycemia or post-meal spikes. Now, managing blood sugar in diabetic gastroparesis involves adjusting the diet, carefully timing insulin doses, and using medication to improve glucose control and gastric motility. Pharmacologic treatment for diabetic gastroparesis aim to improve gastric emptying and relieve symptoms. Erythromycin stimulate motility but may lose effectiveness and has cardiac risk. Betanicol is a backup option with side effects like cramping and low blood pressure. Botulinum toxin injection into the pylorus can occur temporary relief in severe treatment-resistant cases. Now, there are emerging therapies for diabetic gastroparesis which include investigational drugs that are listed here, advanced endoscopic procedures for severe cases, and experimental strategies like microbiome-targeted treatments. Now we go to urogenital autonomic dysfunction in diabetes. It commonly affect the bladder control and sexual health in both men and women. Though often overlooked, this issue can significantly reduce quality of life. Diabetic and urogenital dysfunction causes bladder issues like incontinence and UTIs, and sexual problems such as erectile dysfunction and a reduced libido. These are common, often under-recognized, and significantly affect quality of life. Diagnosis of urogenital autonomic dysfunction in diabetes includes clinical history, physical examination, and symptoms questionnaires. No? Key tests assess bladder function, for example, post-void residual uroflowmetry, urodynamics, and in sexual health, for example, erectile dysfunction index, Doppler ultrasound, and the autonomic and neurovascular tests help clarify the underlying causes. Management of diabetic urogenital dysfunction includes time voiding, pelvic exercises, and medication for bladder symptoms. Catheterization or drugs may be needed for retention, while UTIs require bladder care and glycemic control. Sexual dysfunction is treated with PDE5 inhibitors such as sildenafil, with additional options like vacuum devices or hormone-based therapies for tailored care. Now, treatment-induced neuropathy of diabetes, or TIND or TIND, is a rare, painful condition that develops 2 to 8 weeks after a rapid A1C drops of at least 2 or more percent over 3 months, especially in patients with long-standing hyperglycemia. It affects small nerve fibers and often present with autonomic symptoms. This slide illustrates that a rapid A1C reduction, the larger reduction from 2 to 6% within 3 months, was linked to a noticeable rise in the symptoms associated with diabetic autonomic neuropathy, meaning that the greater reduction of A1C over 3 months is linked to a more pronounced increase in symptoms of diabetic autonomic neuropathy. While once linked to osmotic shift, newer evidence suggests a cytokine surge drives nerve injury, Gradual glucose reduction is now advised to prevent this complication. So in summary, diabetic autonomic neuropathy is common yet unrecognized complication of chronic hyperglycemia that disrupt involuntary control of the heart, gut, bladder, and sweat glands. Symptoms develop gradually, making it a silent condition. Diabetic autonomic neuropathy affects 20 to 50% of patients, more often in type 1, and when cardiac involvement occurs, a 5-year mortality rate approaches 50%. Chronic high blood sugar or chronic hyperglycemia triggers various pathophysiologic mechanisms such as oxidative stress, inflammation, small vessel damage, disrupting autonomic control across multiple organ systems. Clinical manifestation includes orthostatic hypotension, gastroparesis, bladder dysfunction, sexual dysfunction, and abnormal sweating. So lastly, management includes sugar control, medication, lifestyle changes, and targeted treatment for gut, bladder, sexual, and sweat-related symptoms. So with that, I would like to conclude the presentation. Thank you for listening.